When we were talking about non-rebreathing systems, and in the chat on Friday, I had put the weight requirements, but for 15 pounds and under. And the key with the non-rebreathing systems is where you hook them up. You bypass the carbon dioxide canister, you bypass the pressure manometer, the unidirectional valves, and there's lots of different types of non-rebreathing systems. But what they have in common, they all hook up in the same place. Sometimes they're built into the machine. Sometimes they're like a little arm that comes off the machine. At school, they're hanging and you guys will hook them up directly to the machine. But basically, if you look at the different types of names, the most common that you guys will use is the Jackson-Reese circuit. Sometimes people use what's called a Bain system or a Bain coaxial circuit. And if I look at the picture here, these are the different types of configurations, and these are in your book, which will be bigger for you, obviously. And you kind of have to, whenever you get to your externship, you have to see which kind of non-rebreathing system they are using. What is their configuration? But what's most important, again, is to understand that they're all for 15 pounds and under. They all bypass those parts that I talked about. And how we direct the flow in a non-rebreathing system is through the flow rate. So when you calculate your oxygen flow rate, even though these patients are smaller, you're going to be calculating a higher oxygen flow rate. So the oxygen flow rate is not necessarily based on size. It's not like a 100-pound dog is going to have a higher flow rate than a 15-pound cat. It's actually going to be the reverse, because the flow is what's getting rid of the exhaled gases and keeping everything moving in one direction. And again, most non-rebreathing systems do not have that pressure manometer that tells you how deep or how much pressure you're bagging. You can get an adapter to add to a non-rebreathing system. They didn't have those in my day, but you can get those and use those for the non-rebreathing systems. So when we look, you know, obviously when you hook up a non-rebreathing system, you know, and when you hook up a machine in general, I'll give you an example. You have to check, and let's kind of, what's the flow? You check your oxygen. Number one, make sure it's turned on. Make sure you have enough oxygen for the procedure. And then you're going to hook up, when you set up your anesthetic machine, you know the patient that you're doing. So you know their weight and size, and you're going to hook up your breathing system and bag, and then you're going to close it off and test it for leaks. Now, part of it is in that video that I had posted. I will also show you during week 8 when we're in person how to leak test a machine, because everybody has to do that before you use your machine on the patient. And then make sure that your pop-off valve, after you turn off you close the pop-off valve when you check a machine. You have to close the pressure. But you have to open that back up so that when you bring your patient in there, then the machine is ready to go. So we kind of do all of this ahead of time. This is showing you just some of the connections for the non-rebreathing systems. FGI is fresh gas inlet. And so you always have a hose that's bringing fresh gas to the patient. ETTC, endotracheal tube connector. This is where the patient would be. And then when they exhale through this corrugated tubing, and this is the rebreathing bag. So all non-rebreathing systems have a bag, usually a 500 ml bag. And then it can go out the scavenge system. So this, remember, anytime that should say coaxial. Anytime you have a coaxial tube, it's just a tube within a tube. And this is showing the fresh gas flow comes in through the exhalation tube. So these different pictures are just showing you different configurations of different non-rebreathing systems. And that's, so to not get confused, it's just showing you different schematics. I told you some machines could have what's called a control arm. And so your machine might look like this, and it has a little piece over here that has a non-rebreathing system. And this is this clear hose down here that I'm pointing to is the fresh gas inlet. It's going in that blue hose to the patient, and then they exhale through this clear hose, and this goes out. Here's your rebreathing bag, and then letter C down here, this is your scavenge system. So this is just showing these different types of connectors that can be on your machine, okay? Now, again, I told you, number one, you guys won't have to really choose a machine because each station in surgery has an anesthetic machine, and then you have to put it together. It's broken down every day. So part of your job in the morning is set it up, and before you leave, at the end of the day, you have to take it apart and disconnect it and turn off the oxygen. So you have to check your oxygen and anesthetic, choose your system, pressurize it, and make sure you know your oxygen flow rate. Now, you guys, when you get into surgery, you will have a packet, and it has all of the drug calculations, and it has all the oxygen flow rate calculations. And so I think usually the day before, you'll be assigned a patient and you will submit your calculations. So you'll have your flow rate assigned, and you'll have your, you'll know all of this, what, you know, if you're using ISO or SIVO. Basically, the dental patients use SIVO and the surgery patients use ISO. So that'll all be predetermined, but you come in and, you know, about 300 pounds is the cutoff to review. I talked about breathing circuit. Again, to review, 0 to 15 is non-rebreather, 15 to 30 is pediatric rebreathing system, and 30 and up is an adult rebreathing system. So those are your cutoffs for your patients. And then your bag size that you calculate is, we do 30 mils per pound. And again, to review, if it's like, very rarely are you right on the money, and the bags are in even liters. So if you calculated 1800 mils, 1800 mils is equal to 1.8 liters, and that bag doesn't exist, you would always round up to choose the bigger bag to make sure you have enough room for your patient. And when you choose all that, you connect it, you make sure the scavenge system is on and connected, and then checking your oxygen tank and making sure it is turned on. And when you turn on your oxygen, again, you're going to check your pressure gauge that tells you how much pressure is in your tank, which is in PSI. And then you're going to check your line pressure gauge, which tells you how much pressure is going to the machine, which again should be no more than 50 PSI. So you have two different gauges that have to be checked. Fill your anesthetic, and then, you know, we've already talked about how we, you know, when you set it up, what are we looking for, you know? And so your breathing system, number one, is going to determine which parts of the machine you're using. So again, a non-rebreathing system, you don't have soda lime, you don't have a pop-off valve. There is a valve on the breathing system that is called an open-close valve that you can open. Well, it's open when the patient's breathing, and you can close it to squeeze the bag. The big thing is when you go to give a patient a breath, if your pop-off or your open-close valve was open, when you squeeze the bag, it all goes out the scavenge system. And so in order to make the breath go to the patient, you have to close the pop-off valve or the open-close valve so that it goes actually into the patient. And we will practice that when we're with the machine. So I'm not worrying about calculating the flow rates. You will talk about that when you go through your surgery packet. I do want to mention for example, if you were going to mask a patient or box a patient down, which you guys don't typically do in surgery, those do require a higher oxygen flow. Usually we don't calculate that. So normally when you mask a patient, we run about 2 to 3 liters of oxygen per minute. So usually set your flow rate or your flow rate to 2 or 3 liters. And if we're doing that chamber where they're in a box, usually we're upwards of 5 liters. We just turn it up. 5 is the top of the flow meter. You can't really go higher than that. And then because you got to fill that box, so we don't want to run a low flow. And then when you hook them up to the breathing system, you turn them down to their normal flow rate. Now, if I have a little practical tip, if I have an animal on a mask and their cheeks are getting really, really full, you might be running too high of an oxygen flow rate because, again, you can't force it into their trachea. They have to actually inhale. Sometimes patients will try to hold their breath because the gas has an odor. And sometimes when they initially fight it, they might get those like puppy cheeks when you're masking them. But once they start inhaling and exhaling, that typically stops. So don't worry about the flow rates in a closed system. We're not talking about that. We're talking about, I won't go over that. So taking care of the system, obviously, the one thing is, first of all, making sure on your anesthetic machine you take care of your gas cylinders, your oxygen tanks. Normally, you should always, again, your tanks in surgery have 2 tanks. They have 2 yokes. So there's like a splitter, and you can hang 2 oxygen tanks. One is always the one you're using, called in use. The other tank should always be full. So when you come into surgery, you always want to make sure that you check that someone didn't forget to change. If one of those tanks goes empty and you switch to the other tank, at the end of the day, you want to take off that empty tank and put on a new full tank. So you want to make sure that there's always a full tank and then an in-use tank. The tank line and pressure gauges don't typically need anything done. Again, your pressure reducing valve should be automatically set at your 50 PSI, so you shouldn't have to adjust that. And your pressure reducing valve, that's the pressure. And then the flow meter is, you just want to make sure that when you turn it up and down, that the ball does move. I will say, if you have an older machine on the flow meter, and I can go back to that picture, but the flow meter, it's a clear tube, and there's usually a ball or what's called a bobbin, and it floats based on your oxygen flow. Sometimes it can stick. So all I do is turn up my oxygen flow up and down and make sure it's moving. If you turn it up and it stays in one position, then potentially sometimes debris, dust can get in there and it can stick. We had one at Purdue that was kind of temperamental. Sometimes if you hit it, just tap it with your finger. Sometimes you can get it to move. But you just want to make sure when your oxygen's turned on and you open your flow meter, you should see that bobbin or ball move up and down. The vaporizer, as far as care, typically you just make sure it's full. You just make sure that you have the appropriate gas in it, and you just make sure it doesn't tip over. A lot of people roll these machines back and forth in their clinic. If you hit a bump and it tips, you have to call the company, and they usually come out and service it. Or sometimes you can disconnect, and you take the vaporizer off, put it, usually have to drain it and send it back to the company. But, like I said, we have a company that comes to the clinic, and they, I think every 6 months, service our machines, and they check the vaporizers, make sure they're accurate. And then the other thing is, you're constantly, every time you use a machine, you're checking it for leaks. There is, the tubing that goes to the vaporizer, and the outlet of the vaporizer is a black rubber tube. You just want to make sure you don't see any cracks or holes where it would be leaking. But again, if one of those tubing developed a hole, when you go to leak test it, it won't hold pressure. So if you're having trouble, one thing I do where there's connectors is you can get a bottle of like soapy spray water and you can spray the plastic tubing when you pressurize it and you look for bubbles. So it's kind of a trick if you can't find, you want to make sure there's no air leaks, because if you spray soapy water and there's an air leak, you'll see bubbles formed and then you'll have a problem. Making sure your unidirectional valves are moving, and when a patient breathes in and out, they should move. If they're not moving, they have to be checked, and making sure your pop-off valve isn't sticking or staying in a closed position. The breathing systems are typically, well, I'll say what you should do and what people do. I believe at school, they'll have you clean these tubes, these breathing tubes, between each procedure. And then usually they have to be hung to dry. Sometimes what I'll do is I've taken breathing tubes outside and I swing them to get all the water out. You can or you can try to shake them out. But especially with us being, using shelter animals or rescue animals, and we sometimes will get a breakout of kennel cough, and, we don't want to spread that to patients. In practice, sometimes people, clean them once a week, but, especially if you had a patient, that had maybe a little bit of a cough beforehand, or a cat that's been in isolation, you probably definitely want to clean all of that tubing. You clean the endotracheal tubes. I usually wipe out the chamber after it's done. I clean the masks after we've used them. And then I've talked to you about the carbon dioxide. It should be changed once a month, or if it turns purple, then you want to go ahead and change it. But at minimum, the carbon dioxide is typically changed once a month. So again, for the laryngoscope blades that have the little light bulb, I don't typically submerge those. You can disconnect the blade. I usually wipe it off with an alcohol swipe or like an alcohol gauze. And the endotracheal tubes, again, are soaked typically for 5 to 10 minutes in that chlorhexidine solution. There's usually a tub in the sink, and when you extubate your patient, you go ahead and put it in that tube. We just don't want to soak them all day in that cleanser and then wait till the end of the day, because that plastic can absorb the cleanser. You just want to make sure it's cleaned really well. Okay, so that's the nuts and bolts of, let me see if I can open, let me see. I'm trying to find, I have a picture to review with you. And hang on. Actually, let me pause recording. Okay, I will put this on your page. Part of your homework going over the machine was, the flow through an anesthetic machine. And so I kind of drew this out, and maybe big sneeze. And so I kind of drew the flow through a machine and put some little notes about things. So to review, and this is kind of like going back to the homework, is we're always going to start with an oxygen source, which is on your machine or via a bank. Your E tanks are your little oxygen tanks, and your H tanks are usually a bank of tanks that feed the entire hospital. Both tanks, though, do measure at 2200 PSI. So both, an H tank just holds more oxygen, but they're under the same pressure. And I colored this green because oxygen lines are green, flow meters are green, tanks are green. And also a safety mechanism is there's that pin coding. An oxygen line will only plug into an oxygen drop, and an oxygen tank will only hook up to an oxygen yoke. So there's a pin coding system for safety, and also a color coding system. After you turn on your oxygen source, you're going to read the gauge and make sure you know how much pressure do you have in your tank. Again, the maximum is 22 psi, 2200. And then it's going to go through a pressure reducing valve. And that the job of that is to reduce the flow to safe operating pressure, which it's usually 40 to 50 psi, but 50 psi is the max pressure, and that will slow it down before it goes to your anesthetic machine. And then usually somewhere after that, sometimes this stuff is kind of close together, there is what's called a line pressure gauge. And this is telling you how much oxygen is going into, or what is the pressure going into the line. And again, if the pressure reducing valve is properly set, you only have 50 psi going to your machine, okay? After it goes to, it leaves there, the line, the oxygen line goes to the flow meter. Now, do you see what I have written here? I have flow meter or flush valve. When you turn the machine and you look at the back of the machine and you see where the oxygen comes into the machine, there's usually a splitter, because some of your oxygen is going to go to your flush valve and some is going to come into the flow meter. Now, the flow meter sets the flow of oxygen through the vaporizer and to the breathing system. And this is measured in liters per minute. So like if you put it on 1, then you're delivering 1 liter a minute. The maximum pressure, which you do not measure, there is not a pressure gauge by the flow meter, but just know that the max pressure that can come out of a flow meter is 15 psi. So theoretically, after the flow meter, the pressure is further reduced to 15 psi. But it is set, or now, if you remember, I talked about there's rules for the flush valve. This is an emergency. My abbreviation, E with a circle, means emergency. So if you have to really quickly get a blast of oxygen to the patient, and this is 100% oxygen, you're going to hit the flush valve. But the key here that I wrote, it bypasses the vaporizer. So some key times that you use the flush valve: you can use it to check the machine in the morning. You can, when you're going to recover the patient, when you want to wake them up and you want to fill the bag with 100% oxygen, and you want to hit it, remember, with little short bursts. You don't want to hold it because it can deliver 75 liters a minute, which is a super high flow rate. So you really want to be safe and hit it quickly. You can also use it during CPR to keep the bag full. You never, ever want to use it during a procedure when the patient's under anesthesia to fill your bag, because it dilutes your anesthetic. So if your patient's breathing rapidly because they're getting light, because they feel something, if you keep hitting the flush valve, you're just going to keep diluting your anesthetic. You're going to wake them up. So, and you also don't want to use it for patients that are 15 pounds and under. The way you guys set up non-rebreathing systems at school, you can't use the flush valve. The way it's connected, you cannot use the flush valve with the non-rebreathing system. But there are machines out there that are hooked up in a certain way where you could use the flush valve. So I just, if my patient is small, 15 and under, I do not use the flush valve. Anytime you have to fill up your bag, all you have to do is turn up your oxygen flow. You're going to calculate a minimum flow to run throughout the entire procedure. But if the bag ever gets flat, sometimes a patient breathes rapidly, sometimes something gets disconnected, sometimes you have to fill that bag, that rebreathing bag. All you have to do is crank up your oxygen flow rate. It'll fill the bag and then go back down to your maintenance flow rate. So that's probably, you know, like I said, during the procedure, that's the best way to do it. After the flow meter, the next thing is going to be the vaporizer. I was trying to get creative with coloring here. I did purple and yellow because ISO is purple and SIBO is yellow. So we use a Precision VOC, a vaporizer out of circuit is the common one. The max that we run with ISO is 5%, SIBO is 8% because they have the different MAC values, so they are set in different percents. But when you do set that vaporizer, if it says 5, and this is something you need to know for the test, it's like it's 5%. It's not 5 liters, it's not 5 psi, it's not 5 CmH2O. The number on the dial is the percentage of anesthetic gas. If you have it set at 0, then you have no gas going to your patient. So that is common that sometimes you want to use it just for oxygen. As long as your vaporizer is off or at 0, you have no gas. And remember, each vaporizer is specific. They are not interchangeable. So that's why they're color coded. So remember, for your vaporizer, you have your inlet and then you have your outlet. And at the outlet, you have oxygen and anesthetic, if it's on, and then it's going to be cooked up to a tube somewhere near the inhalation valve. Now, the inhalation valve is one of the unidirectional valves. There's 2 unidirectional valves, inhalation valve and exhalation valve. It is only open when they inhale. So when they inhale, it opens, and then when they when they inhale, it goes to the inhalation tube. Now that's part of the breathing system that's hooked up to the machine. And once it goes through the inhalation tube, it's going to the patient, it enters the endotracheal tube and the patient, and then the patient inhales the anesthetic gas and oxygen. And when they exhale, it goes out the exhalation valve. So that's why I've put it in this order. And when they exhale, the exhalation valve opens. Now, after the exhalation valve, everything is kind of like one location, but immediately after the exhalation valve, you have to have your CO2 absorber, your soda lime canister. And again, those granules remove the exhaled CO2. So when they exhale, those little granules absorb CO2, and then the leftover gases, which is, the gases that, when they exhale, the exhalation is CO2, but it's also some oxygen and anesthetic that they did not use or that they're getting rid of, because there's always gas exchange. So the rest of that is going to go through then a pressure manometer. So the manometer is usually somewhere after the exhalation valve by the soda lime canister. You see a gauge. That gauge is measured in centimeters of water, or CmH2O. And that is measuring the pressure within the system and the machine. Remember, you have a patient with an endotracheal tube, and then you have breathing tubes, and you have an anesthetic machine. And when they're breathing in and out, there should be no pressure in the system. That gauge should be at 0. Every once in a while, you see it maybe move to 1 or 2 when they take a breath, but most patients don't even move it at all. But when you go to give a patient a breath and you close your pop-off valve, now your system is pressurized because it can't go out the scavenge system. When you close the pop-off, you have no scavenge. Okay, so now all the pressure is in between your patient and the machine. And this is where your bag will start to get full, and then you squeeze, and you want to watch your gauge and make sure you don't go above 20 centimeters of water. That is normal ventilating pressure. After you give your patient a breath and you let the bag go, you're going to open your pop-off. Now for you guys, it's just a little button. You're going to push it, squeeze the bag. You hold it down when you squeeze the bag, and then when you're done, you let it go, and then the pop-off's open. But some machines, you actually have to close it like a dial, squeeze, and then open the dial. Always make sure your pop-off is open, because if not, you will kill your patient. And how you know you're getting pressure in the system is you always look at your rebreathing bag. As long as your bag, again, it's like porridge. I don't want it too full and I don't want it too flat. I want it just right. And as long as you have a patient, as long as you don't have any leaks and your pop-off's open, you should always have a little bit of gas in your, because remember, your flow meter is on. You're always delivering oxygen to the system. So there's always a flow. Even when your patient's not breathing, there's pressure coming into the system. But again, as long as your pop-off is open, you're not going to pressurize. Somewhere after the pressure manometer, you have the pop-off valve, adjustable pressure limiting valve. Some people call it the APL valve. I call it the pop-off. Always open. There's the only time you close the pop-off is when you're giving your patient a breath and when you're checking your machine for leaks. Other than that, it is always open. And the common mistake people make is you'll go in the OR, you close it to check the machine, and then you forget to open it. And then you go to bring your patient in there later and you hook them up and it was left closed. So when you're done checking the machine, always make sure you keep that pop-off open. Keep it open. Somewhere after the pop-off valve, underneath the pop-off valve, that's where your rebreathing bag is going to be. Now the rebreathing bag is set in liters. So I have a mark, I have that it's set in liters. There's a 500 ml bag, which is a ½ liter. And then it goes 1, 2, 3, 4, 5 for small animal. And then large animal has a 15 and a 30 liter bag. This bag holds a mixture. So it is fresh oxygen and gas for your patient. It's fresh. And then you're also going to have recycled gases. This is why it's called a rebreathing bag. So in the bag, you know, because you have your oxygen and gas, it's always filling with oxygen and fresh gas. Because when your patient's not breathing, if it doesn't go into your patient, it goes into the bag. And then when they exhale, after the CO2 is removed, those recycled gases go in the bag. So when the patient inhales, you see the bag collapse because they're pulling from that bag when they breathe. And when you go to give them a breath, you're squeezing that bag. So that rebreathing bag, and again, the rule is 30 mils per pound. I do want you to know this calculation, 30 mils per pound. And depending on what you calculate, you always round up for your patient. After the rebreathing bag, again, it can either go back into the inhalation valve. Number 7 through 14 here, this is kind of where everything circulates in the circle, okay? After the rebreathing bag, some of it's going to go back into the patient, or I have a little note here, it's at the bottom. It can go into the scavenge system, and the scavenge system is what takes the exhaled gases and relieves excess pressure. Now the scavenge system, there's 2 types of scavenge systems. You can either have what's called active or passive, and an active scavenge system is a suction system, and it actually suctions from that tube. That's what we have at school. You'll see a machine up by the ceiling. It has a little on-off button, but basically it actively suctions, and this is what we had at VCA. If you have what's called a passive system, when you guys do the dentals, usually you hook up to this little canister called an F-air canister. It's a little charcoal filter because we only have one scavenge hose or pipe in the prep room, but sometimes you have 2 tables going at once. So only one can use the active scavenge. The other people use F-air. Some people, it's a pipe in a wall, and you hook it up, and then when the wind blows, it takes the gas. Some people, I've seen clinics stick it out a window. You just don't want it laying on the floor, because then you are sitting there breathing all those exhaled gases. So that's the basic flow through a machine, and that is, are there any questions? Where is my mouse? Oh, there we go. Are there any questions on that part of the diagram. If there's not, that's okay. Let me real quick go through. I only have about 500 windows open right now, so let's try and do this. Okay. So that's kind of what, that kind of answers number one, and I probably answered some questions on the homework based on that diagram, but that goes through the parts, and that goes through the flow. It's just like when in anatomy, when I have you trace the flow of a red blood cell through the heart and the circulatory system. It's kind of a similar concept. When you turn on an oxygen tank and an oxygen molecule leaves, where does it go through the patient? To review, the difference between a Cole and a Murphy tube is a Murphy tube has a hole, which is a Murphy eye, which allows another area for gas to enter the tube if the end gets plugged. And also the Murphy tube typically has a cuff, and a Cole tube is a cuffless tube, usually used on exotics. For choosing a tube, we use the ID size. So on an endotracheal tube, you have an ID, an OD, and a centimeter number. If I say go get an 8 endotracheal tube, you want to look for the ID number that says 8.0, and that's the internal diameter. But that's how we size tubes. And the strongest tube is the silicone endotracheal tubes. That is the strongest material. And what are the disadvantages to the orange tubes? The orange tubes, number one, is they are absorbent. So they tend to absorb chemicals like the cleansers. You also cannot see any fogging in the orange tubes. You can't see any discharge. A lot of patients, sometimes you pull a tube and you can see blood in the tube, you can see mucus. And again, those orange tubes, and they can get damaged very easily because they're super soft, which is nice because they aren't atraumatic. You know, they're smooth when you put them in, but I'm really not a fan of the orange tubes. What are advantages to intubating? Number one, you establish an airway. So in an emergency, you have access. You decrease what we call anatomical dead space. Remember, now this was the very early part of our lecture, but you're going to get the gas closer to the lungs. Every area of the respiratory tract is considered dead space because there's non-functional gas exchange. So you're getting gas closer to so it's efficient delivery of anesthetic. You have airway access. So if in an emergency we can ventilate, you cannot put a mask on a patient and bag them. If a patient goes into cardiac arrest, you cannot put a mask on them, and you can't hold oxygen up to their nose. You have to force oxygen into their lungs. So you're going to have to establish an airway and intubate. So if you already have an airway in, we're already ahead of the game. To inflate the cuff, number one, to prevent leakage of anesthetic gas, because again, the tube is very rarely a perfect size for the trachea. There's always a little space. So prevent leakage of anesthetic gas, also to prevent aspiration of stomach contents, regurgitated fluid. It is not to hold the endotracheal tube in place. It should never be tight enough where you can't pull that tube in an emergency, because if your patient starts chewing, if they wake up prematurely, the number one thing you got to do is you got to get that tube out of their mouth so they don't bite it and swallow it. And again, if your tube, there's been plenty of times where I'm fiddling looking for a syringe to deflate the cuff, and sometimes I'm just like, I got to pull the tube. He's waking up and I got to yank it. So you don't want that cuff too tight, because also to cause tracheal necrosis. Some of the disadvantages to intubating, it can be traumatic and it can cause vagal stimulation, but there's way more advantages. There's way more justification to intubate every single patient than it is to not intubate, even though there are downsides to intubation. Induction chambers, those are primarily for aggressive patients, fractious patients. Again, not a great method of induction. High stress, the patient can hurt themselves. I can't monitor them in that box. You can watch them breathe. And sometimes they'll push and you can look at their gum color. But again, you're not going to be opening the box to take a heart rate and check their blink. You just have to kind of watch them breathe. And when they get sleepy, then you can pull them out. 7, carrier gas is oxygen. That's the only carrier gas that we use. Nitrous is a adjunct, or we use it in conjunction. I talked about safety methods, the color coding, the pin coding system. H-tank is bigger than an E-tank. E-tanks are portable. H-tanks are typically chained to a wall and deliver oxygen to an entire hospital, versus an E-tank is typically on a machine or is portable. A tank holds 2200 PSI. Safe operating pressure is 50 PSI to a machine. Yes, Bethany, that's a really good question. For example, sometimes my doctor wants to just use propofol to give a patient anesthesia for maybe like biopsies or like a short, maybe some x-rays. And especially if it's like a brachycephalic, I will put an endotracheal tube in and not hook them up to anything. No oxygen, no inhalant, but I have an airway placed. The problem is you can't place an endotracheal tube without an induction agent. Like Dexdome Torb, if you're doing sedation, they typically have still enough jaw tone and still enough swallow where you can't put a tube in. But if I use what's called, and next week we're going to talk, or this week, we're going to talk about canine feline anesthesia. I'm going to talk about some of these techniques, but you can do just IV induction, have a tube there just in case. So I do do that in certain patients. PSI is your oxygen tank. That's what's measured in PSI. Centimeters of water is your pressure manometer. Liters per minute is your oxygen flow meter, but your bags are also measured in liters. Your vaporizer is set in percents. Mils and liters, basically your flow meter can be measured in milliliters if you're below 1 liter, and also certain rebreathing bags come in milliliters, your 500 ml bag. A VOC is a vaporizer out of circuit, VIC is in circuit, and this is within the breathing circuit. The VOC is out of the circuit. It is not affected by the patient's breathing. You said it. We currently use a VOC, which is also called a precision vaporizer. Which systems use a non-precision vaporizer? And that would be the vaporizer in circuit. That's the type of system. I already talked about the flush valve, when to do it, when not to do it. 16, a vaporizer in circuit is affected by respiratory rate because it's in the breathing circuit. I already told you the weight ranges. Adult rebreathing is 30 and up. Pediatrics 15 to 30, non-breathing's 15 and under. Flow of gases in a rebreathing system is your unidirectional valves. In a rebreathing system, your unidirectional valves control the flow in the proper circle. And the pop-off valve is so you can bag. I think I answered the rest of these questions. The last one, 2 names of non-rebreathing systems: a modified Jackson-Reese, an Ayers T-piece, a Bain coaxial system. Those are all different types of non-rebreathing systems. But also know for the test, what parts does a non-rebreathing system bypass? Okay, I know I had to do that really fast because I got to make sure you guys can get to your other classes. Do you have any questions?